Hi everybody, welcome to the Walk-in Day 2020 with Total Health as a topic. My name is Daniel Walker. I'm the managing partner of walkerproject, located in Zurich, Switzerland. We will have speakers from Spain, Sweden and Switzerland on the topic of total health and the learnings from COVID-19. The topic total health means this is the future of healthcare. That's what we think about it. It's customer-centric, it's better quality healthcare, it's lower cost healthcare, more integrated, and it's digital. We will have 3 examples of it, and I'm happy to welcome them. To the goals of the Walk-in Day, we would like to learn more about the key elements and the advantages of total health, make a connection between COVID-19 situation and how total health systems manage the crisis. Very interesting insights from Spain and from Sweden. See how total health could be implemented in Switzerland, and meet interesting people, discuss how healthcare systems can be developed towards more patient customer centricity. From the program, we will have first keynote from the leaders of our competence centers from walkerproject. This will be about our learnings during COVID-19, followed by a keynote about the integrated care case of Hallstaden, Ramses Sante. In Sweden, Carl-Johan Roberts will be our speaker. The second keynote will be about population health, the case of Ribera Salud in Spain by Manuel Bosch, and the introduction of the total health system in Switzerland by Antoine Hubert, entrepreneur and very interesting personality who tries to implement total health here. Okay, that's it, and we will finish with a Q&A. Welcome to this webinar. Jaco will be our facilitator, our moderator, and Christoph Federle will talk about the learnings of the Competence Center hospital construction during this COVID-19 crisis. Rafa wrote about the lean healthcare department. Same Fabian Bischoff, but same, and Stefan Merkel will present another case. So that will be the first part. It's your show, Jaco. Go ahead.
Thank you, Daniel, for the introduction. We will now start with the first keynote, which is a combination, as already mentioned by Daniel, of 3 keynotes, 3 short keynotes. Each competence center at walkerproject, namely, as you can see from the slide, lean healthcare, hospital planning, and strategy and M&A will have 5 minutes, where they will shortly explain what happened at walkerproject during the COVID-19 crisis, and also share with you the key learnings. Fabian and Christoph, the stage is yours. Please feel free to share your PowerPoint and start with the presentation. Thank you, Fabian.
Thank you, Stefan. Thank you, Jaco, for the introduction. Let's jump directly into the Competence Center hospital planning. Most of you already know that we base our approach on design thinking with all those prototypes to create a sustainable building, and in terms of strategy and operations. So we really want to deliver something that works at the end. This is the biggest goal, and this starts at the very beginning of a hospital planning project. We're very keen on developing a very robust and integrate innovation from the very front end of the first discussions. For all those things, we integrate the physicians, the nurses, the architects, the IT, and so on. At the end, it needs to lead to a building that supports the processes on a maximum level, of course. The case that you see here is linked to a major outpatient clinic provider in Switzerland, where in about 3 days, we have defined the detailed future processes and enabled architecture to realize the infrastructure according to those definitions. So we are heavily involved in those year-long planning of major hospitals in Switzerland and Europe. And as you can imagine, we learn through every new hospital planning. And of course, in this infrastructure environment, we observed, for example, that investments in hospital architecture are often not enough evaluated from a functional process perspective. So the business case itself does not include the functional case, and the business case itself is based on very optimistic numbers because it doesn't really integrate that functional perspective that at the end costs so much if they do not work. Fabian, as our leader of the Competence Center, will lead you through this analysis opportunity, and I hand over to you, Fabian, to tell us more about this.
Yes, thank you, Christoph. I think many of you already know those kind of projects that Christoph just talked about. So I'd like to take the opportunity to introduce you to something else we did in our Hospital Planning Competence Center. And that some time before and during the pandemic, we developed an assessment grid for healthcare infrastructure that helps investors and owners evaluate the value of infrastructure from a process flow perspective. And we built around 400 questions assessing functional areas. With functional areas, I mean like ED, radiology, operation rooms, wards, etc. In the second pillar, we looked at the interlink of different functional areas and thus the flows through the infrastructure. Here we normally choose cases with high volume and follow them through the building. And last, we integrate coming projects and trends into the picture to have a holistic view for the people that ask us to do this kind of assessment. As a result, here an example of a summary. All relevant functional areas are evaluated on a functional level. And here what we see is the condensed management summary at the end, or 1 page out of that. And the second pillar, we take the major offerings and patient flows through the buildings are assessed. Here we map a patient floor in this example on the floor plan so that it's clearly visible how easy, or in other cases, how complicated the flow is, focusing here on the patient flow. And finally, a view on how well an infrastructure is ready for future trends in healthcare. All relevant information to determine true and fair value as well as investment opportunities. We performed the evaluation on site for smaller sites during normally 1 day, for bigger sites rather a 2-day session. To facilitate this, we have built a web app that allows us to have a fast setup, standardize evaluation criteria, and results ready quite fast in very little time for the client. On this screen, we evaluate as a very specific example the separation of patient and staff flows in a ward environment. And because that grid is quite modular and easy adaptable, we have conducted such assessments along the continuum of care, not all of it yet, but quite a few different institutions. And even in one case for a digital solution. Of course, there with adapted questions. So this is a piece of work that kept us busy during the last month, and something we could continue also in reduced operation times of clinics, and kept us busy in that time. As Stefan, we're happy to answer any questions. Just get in touch via the chat or directly through any other channel. Don't hesitate.
Thank you very much, Fabian, for your key insights, and Christoph as well. Please, Raphael, our Head of Competence Center, Lean Healthcare. Feel free to start your presentation and your short keynote.
Yes, so I have the pleasure as the leader of our Competence Center in Healthcare to give you a little bit of insight in what we did as a Competence Center during the crisis. Obviously, as a team that works mostly on the shop floor, in the clinics, in the hospitals, it was particularly challenging for us too to continue our work. Fortunately, there were some things we could still be working on even during the lockdown phase. Something that is exemplary of what we see or what we saw during the crisis is the quote you see on the bottom, never let a good crisis go to waste. So basically there was obviously a crisis that had an impact on everyone, but not everyone reacted as well to the crisis. Something we saw is that some hospitals took it as an opportunity to change some things, or actually most hospitals did, obviously, to learn some things, and also to, we saw quite a different level of resiliency in the different hospitals we were able to support or through our contacts. And this resiliency of an organization, this resiliency of teams is something that is the ultimate goal we follow with Lean Healthcare. So basically to help people develop a stable operating system that also works during a crisis, an operating system that lets you focus on your work with patients and is not a daily distraction because you have to solve so many problems. But this is the ultimate thing we'd like to achieve. And as a specific example is the graphic that you see on this slide, that basically operation center that different operation centers we were working on during the crisis and also after crisis, basically bringing together the people, the decision makers you need with the information they need, and with a management system that helps them take faster, better decisions and help their teams to solve problems. What was very interesting is also after the acute phase of the crisis, when it was over, that you actually saw that in actually quite a few hospitals that we know that at least parts of that crisis organization is actually missed, because there were some quite significant advantages. For example, the faster problem solving and the faster decision making. And so why do people miss this? And this is, those are the key learnings or the key advantages that we saw in the operation centers we were able to help, or that we had the experience with. So basically to help people have a better overview, to visualize information better, so to make, to produce information out of data, so make data usable and understandable for the decision makers, to make sure that everyone talks actually about the same thing, to actually establish facts. So for example, the number of beds in a hospital shouldn't be something up for discussion, but you basically have to have this discussion and then use the same data for this. And so to actually foster a consistent and reliable conversation about the different data points. And obviously, as I said before, this speed we saw in decision processes and faster resolving of problems. So what is here to stay from this? And one thing that we already see now, and something that I strongly believe in, that this idea of an operation center as one example of better planning and management of capacities, that is actually something to stay, because after the crisis, the pressure is obviously even higher than before, especially for hospitals, especially for institutions in the healthcare setting. And so we see that you have to better coordinate what you're doing. For example, what you're seeing here is that the different platforms, let's say as an OR and the wards, that what we see very often is that the capacities are not aligned, which means either you have too many beds that then are empty and just part of your fixed cost, or that an OR produces too much, basically you don't have enough beds. And what we see very often is that there's no consistent logic across what's called like patient pathways or patient clusters, but it's mostly everyone thinks within their own profession, within their own clinic, maybe within their own department. But what we actually see is that there's a huge potential of improvement if you better align different platforms and if you improve your managing and planning of your capacities. This is something we started working on. This is definitely something that will keep us busy in the next few months and years. And the last thing that's definitely here to stay from our perspective, that we already integrated in our work, is with what we started actually with design thinking, that we also use obviously in our projects, in our improvement projects on the shop floor. But basically just what we saw even more than before is that to better combine digital solutions with process improvement. And as you see the example here, this is the example of a ticketing system. It doesn't have to be something fancy that you work on for a few months, but rather start with a Post-it, and then maybe after it works well, you start using an Excel sheet, and then if it works well, then go on to build an automatic system. And this is something we see now when we restarted our process improvement work in the healthcare organizations, that actually this plays a much bigger role. So for example, daily huddles, daily team exchanges, that we from the start use digital solutions a lot more, or basically start the prototyping of those digital solutions. And this is also something that will keep us busy. Thank you very much. We are waiting for your questions now, I think, Jaco.
Thank you very much, Raphael, and all the other panelists of Walker Project for your key insights about each competence center. Just a quick reminder, as already mentioned by Stefan and Fabian, please feel free to write your questions. There is a Q&A feature function on the bottom of the screen. Please use it, write your questions. You can also rate and like the questions so that we can pick the most rated, the most liked ones at the end of the webinar in our Q&A session. There will be probably some questions that will already be answered during the webinar, and the other ones, the ones that probably also keep more likes and more rates, then will be discussed together as a plenum. Please, Misha, I kindly welcome you to the stage so that we can together discuss openly with you the open questions that we get through the Q&A function.
Thank you, Jacopo. There was actually one question that I thought we could do a little round of all the three speakers in the beginning. Talking about total health, I think we touched on a topic that we also touched, at least in Switzerland and also in Sweden, during the COVID crisis as well. The coordination of care, the integration of care, is that something that is rather done decentralized in regional organizations, or is it something that should be done on a state level in a centralized manner? Maybe starting with Karl-Johan, what's your opinion? The responsibility, the decision power regarding integrated health or total health, rather centralized or decentralized?
Well, I think we need easy answer. I think we need a bit of both. I think, and what we see in Sweden is that we have regional developments going on where regions are trying to implement some sort of integrated care, but we have a problem with legislation, and I think on a national level, the way the Swedish system works, we have, I think we actually will have a new healthcare act, healthcare law maybe in the next year that will actually make it easier to do integrated care projects. So I think we need a bit of both, and we've seen this in the COVID crisis as well. There's been a lot of great examples on the regional level, working very closely to the patients, trying to find ways to get patients to stay at home and have a mobile care teams taking care of the COVID patients, so they don't have to come into hospital. But we've also had a very committed national leadership for this as well. So yeah.
Thank you very much. Manuel Bosch, your take on that?
Well, I think that it's 50-50. So I think it's more or less act global and we'll apply that locally. So we need some kind of a framework from a legal perspective, but also we need to adapt that to the specific region, area, condition in every single project.
Anthony Hubert, your ecosystem, a national one, the decision power, decentralized, centralized?
Of course, I mean, decentralization have proven its efficiency in Switzerland. So especially in Switzerland, we are a very multicultural country, and it has to stay regional. Maybe not cantonal, because regions are more important than cantons. But we have seen during the COVID that not each region was hit equally, and so there is no reason to treat each region equally. Why do you need to wear a mask in a region where there is a very low rate of infection? So I think that's right, that each region has to be able to set up his own measure and response to this, and we had a national coordination which was okay. I mean, I think Switzerland did well. I mean, maybe the federal government gave back the power to the cantons a little too early, because now the cantons are doing a lot of shit.
Thank you very much. Manuel Bosch, a question that came up during the webinar is whether you could give one or two examples of measures that you took to actually overcome or eliminate the silos between the different parts of the organization.
So that's a good, very good question. I've read that. So one easy example about that is incentives. So we have like a different payment model for doctors and nurses. So more or less 60% of their salary is fixed, and the rest, between 35 and 40%, is incentives. So we can adjust the incentives to provide not more care, not fee for service, not the more they do, the more money they make at the end of the month. Is the better they do, the more money they get at the end of the month. So we can adapt that on a regular basis. Every single year we change the incentive systems. So for example, for primary care, so the accuracy of the people sent to the hospitals is one of the KPIs we manage. So quality measures in the operation theaters, complications, readmission rates, these kind of things being tracked and being measured on a regular basis, and the way we can pay the clinical team regarding that information is one of the critical things and one of the key measures we use to break that silos between different areas or levels of the healthcare.
Thank you very much. When you compare the reimbursement for me as an individual provider before and after, was there a big shift? Is it a different distribution, or what did you see or experience?
That's a very good question. So we have different examples of that. So we have projects where there is only one provider. So there is only one company that provides the full scope of services. So there's no a primary care provider, there's no hospital at home provider, there's only a unique company that employs all the resources. So in that case, it's quite easy to move resources and to change reimbursement and to move people from primary care to emergency departments, or nurses from the wards to hospital at home. So that's one option. The second option is where we have been, so where we needed to integrate different providers. So that's of course we've changed the reimbursement model for them, and that is also that's hard. So every single change is really complex, but it's something that we have done during different years and phases. And of course, there are people that right now are in a different position doing something different, and also with a different reimbursement model than the currently he or she has some years ago.
If I understood correctly, around a third today of the reimbursement is depending on the performance.
Yeah, one is example. So being positive. So we have 45% of the people in one of our projects. Almost all the care they receive is virtual. So we have people making more money or doing different kind of reimbursement for virtual care that does not exist 2 or 3 years ago. On the opposite side, so people that are still seeing patients face to face on a primary care level, so that is having less patients and doing less money. Of course, that's changing.
Okay. Thank you very much. Carl-Johan, the same question went in your direction as well. How does the reimbursement system look in your case, or looked in your case? And it was particularly an interest about the multidisciplinary teams that are treating patients at home.
Yeah. So this was a public hospital and public primary care units, and of course a public municipality. So it was all tax funded, and we had, but one of the good things for us that made our project possible was that partly we had a capitation model for our primary care. So they were capitated. They didn't have to sort of have a fee for service. There wasn't a fee for service model, it was capitation model. And for me as a hospital manager, we had more of a what do you call it, more or less of a lump sum, a budget that was allocated to me at the beginning of the year that I could use to treat and do as much care as possible for that kind of money. So that sort of enabled us to see, okay, how can we provide the same care at a better and a cheaper way? And the way we set up with our mobile care teams, that we did more or less like with an agreement with the other parties, we try to look into the almost profit sharing of that, because there was quite a lot of money to save in the hospital from if we set up this, so we could share some of these profits with the other partners. And in order to do that, we had to build quite a lot of trust. But I think one of the lessons we learned was that you always have to, if you try to set up, I really love what you're doing in Spain there, because I think that sounds great. But if you're doing a collaboration, it has to be a win-win-win solution. The patient has to win, and all the partners has to win, also financially. So we have to be very open and transparent with what the financial gains are, and then share them. And that's what we did.
Thank you very much. All three speakers spoke a lot about what it means for the patient if they get a total, more integrated care. Carl-Johan, one question that was asked during your presentation is the complexity for employees that are working across organizations, or maybe also across geographies. How did that change, and what kind of measures did you take to deal with it?
Yeah, well, it was new. It was, like I said, cultural differences, because we in the hospital, the doctors think in one way, in the primary care they were thought in another way, and municipal care was quite a different thing. So it was complicated for almost everyone. I think the hardest thing was for our doctors that was used to working inside in the hospital, working in the emergency ward with access to lab equipment and X-ray and stuff like that, radiology. And now they had to go out and make clinical decisions out of hospital. But I think that the way we solved that was that once people got working, actually some of the hospital doctors told me this, that when they came back from a day working out of hospital, seeing those patients, the same patients that they had seen before in hospital, they actually felt that they had been of value today. They said that to me. They say, today I've actually made a difference. Treating this patient in hospital would not have made a difference for that patient. And that sort of and just the focus of the vision to actually all parties try to do what was best for the patients actually got us through the most complicated stuff. There was issues and there was conflicts, of course, but what we worked through them. And what we found, and this was quite surprising, that at the end of the project and when we went into another phase, it was actually easier for us to recruit personnel. It was easier to recruit doctors, easier to recruit nurses, because this was a way of working that they enjoyed, and that actually, well, it was possible to work longer in the hospital.
Thank you very much. Now, we know that the Kaiser Permanente manual uses also quite some capabilities to reach out to their patients through their patient portal. You talked also some about the integration of data and information flow. Is that something that you deployed as well, like an electronic patient portal that can facilitate the communication and the flows in the hospital as well as in the integrated healthcare system?
Yeah, as I said before, so we have like a set or full package of integrated solutions. So that includes like a basic electronic medical record that we have developed in-house, a patient portal, and a BI solution. So all the risk stratification, KPIs, incentive system, costing system, all that is developed in-house. One of the key parts is that patient face, which is the way the citizens access to the system, not only for care, for virtual consultations, but also for checking the care gaps, the care plan, also to send information or text message to his or her primary care doctor, change appointments, send information, check tests or imaging results. And last but not least, we have also included there all the training, all the health training, very tailored to the condition of the patient. So in terms of smoking cessation or well-being prevention, that is included in that health portal.
Thank you very much. Carl-Johan, the mobile care teams, how are they coordinated? Who coordinates them, and how does the flow of information look? You're still on mute.
You're on mute, Mr. Roberts.
Oh, classic mistake. I thought I'd learned this by now. Working from home for, okay. Well, I left the hospital in January, so right now I don't really know. But when I left, we've tried different solutions, having it set up and coordinated from the primary care unit. But before I left, we actually transferred it into that it was coordinated from the emergency department in my hospital. But it was a team. It was set up with as a team with primary care and municipal care as well. So, but it was coordinated from the hospital, and we had the budget for it was at the hospital.
Thank you very much. One thing I was wondering, Carl-Johan, you work now in a multinational healthcare organization, have maybe seen different approaches to integrated care, to total health. What's there to learn from, I would say, fairly different healthcare systems in your portfolio at Ramsay?
Well, I think all of the we have Ramsay's mother company is based in Australia in Sydney, and they have also they have the same problems as we do in Europe. So and they've actually tried to set up a joint venture with a private care company that sort of tries to deliver an integrated care platform there as well. So but I think that there are cultural differences. We have the same problems all over Europe, but we have different healthcare systems, and we have to adapt to that. I think one of the drivers, as one of the speakers said before, will be digital care. I think the digitalization of healthcare will drive and sort of it will make us change whether we're working in France or in Sweden. But it's I find that the vision for our company in whether we're based in we have some units in Germany as well, and like I said, in Sweden and in France, it is to provide more of a total healthcare approach. And I think we will have to work with the different nations' legislation to make that work, and the different reimbursement system. But the goal can still be the same, but we have to adapt a little bit differently depending on where we are.
Thank you very much. But before we close the Q&A, is there one last question that someone would like to ask in the chat or live? If so, then you can raise your hand or write it in the chat. John, our senior medical expert, is wondering why initiatives like this for integrated healthcare are very often coming from private healthcare providers and not from the governmental healthcare systems. Do you two share this observation, and or what's your take on it? Maybe Manuel, Bosch?
Well, that's a very good question. So my reflection there, it's that this usually takes years. So it's quite so you need commitment, and you need a period of time of more than 4-5 years to transform something very complex like healthcare. So if you are a politician and you're thinking in your 5, 3 or 4 year projects, even if you do not have like a national agreement between all the political parties, it's quite complex to introduce that change at a scale. And also so from a private perspective, it's quite so the private companies, so we have a lot of tools to make this happen easier, faster, and at some point more efficient. And last but not least, probably we have the right incentives in terms of creating that change, because as you probably know, that will impact in better health, but also will impact in less cost for the company.
Thank you very much, Carl Johan. Stepping from one world into the other.
I thought the difference would be bigger, actually, but it's. I agree with Manuel. I think it's. If I had run Hälsostaden as a private company, I think we might have moved faster because we could see the profits in that. But when you're working in a political, it's a complicated world to be a manager in a politically run organization, because you have different political interests, and also. I think it's a question about power and where it's difficult for one organization's political leadership to give up power to another one. So it's it could be that could be one of the answers, that it's actually easier to describe a business case for the CEO of a company and see that, okay, this makes our healthcare better, and it makes us more profitable, and we can move faster. Like I said, I've been in Ramsey for 6 months and mainly been locked up at home. So I don't really know that much yet about our company. But what I find is that there is an incentive for action that I feel is more palpable here in the private sector than it was in the public.
Thank you very much. Three excellent examples, 3 perspectives on total health. We will continue this discussion throughout the next month, and we'll hopefully also be able to discuss it more collaboratively and in more interaction next year. We have started as well at another front, working together with Ramboll and with White Architects in Sweden to launch a series of webinars. So if you like the one today, that one is of similar fashion, where we actually talk about the hospital response to the pandemic challenge during the COVID age, and what can we learn for the future. It's a series of webinars that look at different ways of resilience, of dealing with resilience. And on the 4th of September, we have a 2-hour webinar on what's actually at the front line. So the roles of leadership, staff resilience, and intelligent modeling. We'll have examples from Europe and the US. So tune in for that one as well. And I would like here to thank the three speakers, guest speakers today, for their perspectives. It was extremely interesting and also good to see that there are different paths towards the same goal. I would also like to ask everyone who tuned in to participate in the poll, which will start in a couple seconds, to give us also an immediate feedback on this webinar. We will send out the presentations plus the recording within the next 24 to 48 hours to everyone who has registered via email. So keep a lookout for that. If you don't get it, let us know. Jacopo, thank you very much.
Thank you, Misha.
This wonderful webinar. And thank you for tuning in. It was a great experience to replace a physical meeting with a streamed one digitally. And stay safe. Thanks a lot.
Thank you very much. Bye-bye.